Okay, let's unpack this. We've got a stack of sources today that take us right to the front line of some really impressive medical breakthroughs, specifically in oncology.
Right.
And if you're interested in how researchers are tackling the absolute hardest cases, and I mean the really tough ones, then today's deep dive is for you. We're looking at a particularly aggressive cancer, drug-resistant, true extramedullary myeloma.
And it's not just a challenging disease. For these patients, it's often a clinical emergency. I mean, these are individuals who have already run out of most standard options.
So we're talking about multiple myeloma cells
Yeah.
that have done something pretty scary. They formed tumors, pyxinocytomas, right, but outside the bone marrow.
Exactly. Outside the sort of safe harbor of the bone marrow, the myeloma hasn't just come back. It's, as you said, it's abandoned its traditional base of operations.
It's established new aggressive beachheads in soft tissue or organs.
Precisely. And the stakes here are incredibly high. Our sources, they really emphasize that patients with this kind of presentation are already at a very high risk for rapid disease progression. So when you combine that specific anatomical challenge with drug resistance, and that means they've already failed multiple lines of therapy, you're dealing with a population that historically had a profoundly poor prognosis.
That context is just so vital. And it's exactly why the clinical results we're focusing on today are so, well, potentially transformative. We're analyzing the findings from the Phase 2 Redirect T1 study.
A really important one.
And our mission for you is concise, to understand exactly how successful this two-pronged dual antibody therapeutic strategy was in terms of delivering a response, and crucially, what was the cost? What were the trade-offs in terms of patient safety and adverse events?
This is a textbook example of high-risk, high-reward medicine. It really is. When you're facing a cancer this complex, a single-target drug, it often just selects for cells that can quickly downregulate that one target and, well, escape.
Right, the cancer just learns to hide from that one line of attack.
Exactly. And that inefficiency is what led researchers to develop this two-target strategy.
So let's get into that offensive strategy. The combination involves two agents, Talquetamab and Teclistamab. So why both? What specific molecular targets were they aiming for to tackle this highly resistant enemy?
This is a classic belt and suspenders approach, but for engaging the immune system. We're dealing with what are called T-cell engaging bispecific antibodies,
Okay.
which means they act like tiny molecular bridges. They physically link a cancer cell to one of the patient's own T-cells to trigger an immune attack.
So the whole goal is just to make sure the T-cell finally recognizes the cancer cell, even if that cancer cell is trying its best to hide its identity.
Exactly. So teclistamab, that's the more familiar piece of this duo. It targets B-cell maturation antigen, or BCMA.
Right, BCMA. We've heard a lot about that one. It's a pretty well-established target in myeloma, isn't it?
It is, yeah. A very well-established target, highly expressed on the surface of most myeloma cells. And, you know, therapies targeting BCMA alone, they can be really effective.
But there's a but coming.
There's always a but. The big problem is resistance. Resistance develops.
So if resistance is the problem, the second agent, Talquetamab, that must be the failsafe. What target is it hitting?
So talquetamab targets something completely different, GPRC5D.
GPRC5D.
Yeah. Now, the full name is a real mouthful G protein-coupled receptor family C group 5-member D, but, you know, you don't need the jargon.
Okay, good.
What you need to know is that GPRC5D is also highly expressed on myeloma cells, but it is distinct from BCMA.
So what's fascinating here is that GPRC5D offers an entirely separate path to attack the malignant cells.
Yes.
If a myeloma cell learns to hide BCMA to evade teclistamab, it might still have GPRC5D on its surface, and vice versa.
Precisely. The goal is redundancy. But there is a crucial biological detail about GPRC5D that is, well, it's central to the safety profile we're going to discuss later.
Oh, interesting.
While BCMA is fairly exclusive to plasma cells, GPRC5D is also expressed, though at lower levels, on specific normal cells in the body, particularly in what's called keratinized tissue.
Like skin.
Like the skin, the tongue, and the nail beds. And this dual expression, this is what explains why the dual approach, while powerfully effective, also carries a predictable and significant toxicity burden.
That's a fantastic nugget of knowledge. So the source material explicitly links the choice of target to the clinical outcomes, both the good and the bad.
It's a direct link.
And let's not forget, this focused Phase 2 study zeroed in only on those patients who were already drug-resistant with true extramedullary disease. They went after the absolute hardest cases.
And that exclusivity is what gives the efficacy data so much weight. We're not looking at a mixed bag of easy and difficult patients here. We are looking at results derived purely from the population that is most in need of a breakthrough.
Okay, let's move from the strategy to the results then. 90 patients were enrolled in this study. They all received the treatment. The median follow-up was about 12.6 months, which seems like a solid period for assessing early durability.
It is.
And remember, the primary endpoint here was overall response rate, or ORR. They were using functional imaging to see if those tumors outside the bone marrow actually shrank.
And this is where the sheer power of the combination becomes just undeniable. The overall response rate, so the proportion of patients whose cancer responded favorably, was 79%.
Let's just pause on that.
Yeah.
79%. For a group of people defined by having disease that escaped the bone marrow and shrugged off previous drugs, what does 79% even mean compared to the historical norm?
I mean, it represents a fundamental shift. Historically, these patients, particularly with true extramedullary disease and what's called triple-class resistance, they would have had expected response rates well under 30%.
Wow.
And even then, those responses would often be fleeting, so achieving 79% suggests the treatment is overcoming the primary mechanisms of resistance that define this aggressive subtype. It is an enormous leap forward in terms of just achieving clinical control.
So response is step one. But the crucial follow-up question is always durability. Did the cells stay suppressed? Did it last?
They did remarkably well. So among that 79% who responded, the percentage with a response duration of at least 12 months was 64%.
So nearly two-thirds of the people who responded maintained that control a full year later. That suggests the T cells, once they were engaged by this dual targeting system, they achieved a really robust, sustained attack.
Exactly. The confidence interval on that data was strong enough to suggest a really profound, sustained effect on disease control. And then the secondary endpoints gave us a crucial glimpse into patient survival.
Okay.
Progression-free survival, or PFS, which just means the patient was alive and their disease had not worsened. That was 61% at 12 months.
And what about the final measure, overall survival?
Overall survival, or OS, was 74% at 12 months. And if we connect this to the bigger picture, achieving a 74% survival rate at 1 year in a population facing this aggressive and drug-resistant version of myeloma, it really speaks to the profound clinical impact of this regimen.
These are figures that clinicians will be discussing intensely.
Oh, absolutely, as they recalibrate their treatment paradigms.
It's clear the combination therapy successfully achieved its goal of aggressive tumor reduction and long-term control. But this is where the conversation has to turn to the necessary trade-off. High efficacy with these T-cell engaging therapies, it almost always comes at a price. We need to look at the full reality check, the adverse event profile.
That is the essential balance.
Okay.
The safety profile here is substantial, and it's highly characteristic of the mechanisms of action we just discussed. Clinicians, they really need to be prepared for the high frequency of specific side effects.
Okay, so let's start with the most common ones of any grade. Which side effects were almost universally experienced by these patients?
Well, because of that widespread expression of the GPRC5D target, not just on the cancer cells, but on normal epithelial cells, the most common side effects were oral and dermatological.
The ones you mentioned earlier.
Exactly. So oral symptoms, including dysgeusia, that's altered taste, dry mouth, and dysphagia, or difficulty swallowing, occurred in a staggering 87% of patients.
That is almost every single person in the trial experiencing significant issues related to their mouth and throat.
Yes.
So given your earlier point about GPRC5D, we can assume this is the direct result of the Talquetamab hitting normal tissue in the mouth.
That is the consensus view, and it's supported by the source material. It's a predictable form of what we call on-target, off-tumor toxicity. The immune activation is so broad and powerful that it affects those non-malignant tissues that are also expressing the antigen.
Okay. What else showed up frequently?
Cytokine release syndrome, or CRS, occurred in 78% of the patients.
And for our listeners, it's critical to remember what 78% CRS means in clinical terms. This isn't just a fever, right?
Not at all. CRS is a systemic inflammatory response. It often requires careful monitoring, aggressive fluid management, and sometimes even specialized medication to, stabilize blood pressure and manage organ function. It requires intensive support. It reflects the massive immune mobilization this therapy causes.
And the third major common event.
Non-rash skin effects were observed in 69% of patients. And again, that's likely connected to that GPRC5D expression in the skin.
Right.
So you've got these three extremely common side effects: oral, CRS, and skin issues affecting well over 2/3 of the participants.
That covers the general symptoms, but what about the symptoms that truly threaten a patient's immediate health? The high-grade adverse events, grade 3 or 4, the ones that require significant intervention or hospitalization.
This is the dramatic comparison point. Grade 3 or 4 adverse events occurred in 76% of the patients.
76%.
Yeah, I mean, think about that for a moment. The likelihood of a patient achieving a massive benefit, a response at 79%, is nearly identical to the likelihood of that same patient experiencing a serious, potentially life-threatening complication at 76%.
Wow. That places the clinical team in a deeply challenging position. It must require significant resources for management.
It does, and the type of high-grade events were most commonly hematologic, so affecting blood counts. Furthermore, the risk of infection was a major concern. 31% had a grade 3 or 4 infection.
So a 1 in 3 chance of a severe infection.
A 1 in 3 chance, yeah. Which is particularly critical given that these patients are often already immunocompromised from all their prior cancer treatments.
So was this high rate of adverse events? Was it managed? And what did the sources reveal about mortality?
The high incidence of these AEs, it demanded significant supportive care. The study really highlights that managing CRS, neurotoxicity, and these hematologic issues was absolutely essential to keep patients on the regimen. Due to non-fatal adverse events, 6% of patients had to discontinue one or both of the agents entirely.
And the ultimate cost?
Sadly, 10 deaths occurred during the follow-up period, and it is vital to break those down. 5 of the deaths were attributed to infection, and 5 were considered related to the study treatment itself.
So that just reinforces that while the therapy is powerful, the vulnerability to infection is its most immediate and serious threat.
Without a doubt.
This study, it delivers a very sharp, very clear picture of the trade-off inherent in this powerful new class of medicine. Let's try and synthesize this for you, the listeners. So what does this all mean?
What it means is that for patients with drug-resistant, true extramedullary myeloma, a population facing, truly catastrophic outcomes, this dual targeting strategy offers a new, meaningful lease on life. The core conclusion from the source material is that 79% of these patients had a documented response.
Right.
And that translates to sustained disease control and very promising overall survival figures at 1 year.
So it represents a powerful new option for a desperate patient population.
It absolutely does. However, the caveat is that the incidence of adverse events of grade 3 or above was high 76% of patients. And this included a significant infection risk and, yes, mortality directly related to the treatment.
And the researchers felt this was expected.
They did. Crucially, they emphasized that this high toxicity profile is consistent with what is observed when each agent is used alone, as a monotherapy. So combining them didn't necessarily create new kinds of toxicity, but it ensured the baseline toxicity of both of these powerful mechanisms was present.
So the ultimate takeaway for you is a clear, balanced understanding. Talquetamab plus teclistamab is a profoundly effective option, but it's one that requires exceptional clinical oversight and very careful management of those specific side effects, particularly the oral symptoms from GPRC5D and the heightened risk of severe infection.
And this raises an important question for future research, building on the trade-offs we've explored. Considering the high efficacy, that 79% response in this resistant population, versus the near equal rate of serious complications, the 76% high-grade AEs, the question becomes, how will future research focus on preserving this incredible anti-tumor activity while specifically finding smarter ways to mitigate the high rates of oral, dermatological, and infectious adverse events that we saw?
That's the challenge that remains, isn't it? Can we maximize the gain by minimizing the biological cost? Thank you for joining us on this deep dive into dual targeting therapies. Keep exploring the implications of these breakthrough approaches in hard-to-treat cancers.